nutrition chapter is always the hectic. They are planning a lot of action plans.
Well, now itself 55 people have joined. See how.
Good evening, sir. I am Dr.
Good
Geeta.
evening. Good evening. Good evening.
Good evening.
Link ഞങ്ങൾക്ക് ഒത്തിരി പ്രശ്നമുണ്ടായിരുന്നു ജോയിൻ ചെയ്യാൻ. അതായിരുന്നു പ്രശ്നം.
ലിങ്ക് ചെറിയൊരു
It is now okay, sir.
അത് I cancel
റെക്കറിംഗ് ലിങ്കാ.
അതാണ്
എല്ലാ പ്രോഗ്രാം അതെ നമ്മുടെ ഐ
ക്യാൻസലിന്റേതായിരുന്നു കാണിച്ചിട്ട് December 22nd. പുരുഷോത്തം സാർ ആക്ടിവിറ്റി ഗ്രൂപ്പിൽ ചോദിച്ചിരുന്നു, അവിടെ ഇട്ടായിരുന്നത് അല്ലേ? അവിടെ സാറ് കയറാൻ പറ്റുന്നത് പറയുന്നുണ്ടായിരുന്നു പുരുഷോത്തം സാർ.
മാഡം
തുടങ്ങിയാലോ?
തുടങ്ങാം സർ. ഞാൻ ഗോപികയെ ഒന്ന് വിളിച്ചോട്ടെ. ഗോപിക നേരത്തെ കേറിയില്ല എന്ന് ഇങ്ങനെ പറഞ്ഞു, അതുകൊണ്ടായിരുന്നു.
ഇനിഷ്യലി ഒരു ബുദ്ധിമുട്ടുണ്ടായിരുന്നു കേട്ടോ ജോയിൻ ചെയ്യാൻ.
അതാ ഞാൻ മാഡത്തിനെയും കൂടെ. എലിസബത്ത് മാഡം കേറിയിട്ടുണ്ടെന്ന് തോന്നുന്നു.
മാഡം ആസ് യൂഷ്വൽ ഇൻ ടൈം.
അതാ സർ. ഞാൻ ഗോപിക ഒന്ന് മെസ്സേജ് അയച്ചോട്ടെ.
പണ്ട് ന്യൂട്രീഷൻ ക്ലാസ്സിന് മാഡാ ഞങ്ങളെക്കാൾ മുമ്പ് വന്നുണ്ട്.
ഡോക്ടർ ഗോപിക കേറിയിട്ടുണ്ടോ? പിന്നെ സ്റ്റാർട്ട് ചെയ്യട്ടെ.
ഞാൻ പുതിയ ലിങ്ക് ഗോപിക മാഡത്തിന് അയച്ചു കൊടുത്തിട്ടുണ്ട് ഇപ്പോ.
ഓക്കെ ഓക്കെ സാർ, എങ്കിൽ സ്റ്റാർട്ട് ചെയ്യട്ടെ. എലിസബത്ത് മാഡം ആക്ച്വലി മാഡത്തിന് കേൾക്കാമോ?
Yes, Geeta, I can hear you.
Okay, thank you, ma'am. Good evening, respected Nandakumar sir, President IAP Kerala, Elizabeth Madam, Dr. Jose, the Vice President South Zone IAP, Dr. Gobi Mohan, Secretary IAP Kerala, Dr. Patani sir, and the speaker, Dr. Gopika, and all the senior pediatricians, my teachers, colleagues, and dear students. I welcome each one of you to the first program of this NutriLearn of this year 2026 under the leadership of State IAP, Dr. Nandakumar and Sir's team. It's with great happiness that I am organizing this. Actually, I wanted the program to start with Elizabeth Madam's talk, but Madam is very busy with the forthcoming the IAP, the Pedicon. So Madam only suggested that we start it. That means we needn't skip it, and Madam has kindly agreed to introduce the topic. So I welcome you, Madam. Thank you for agreeing for being to start this program. And Madam, as we all know, I'm no one to introduce Madam to this audience. We all know Madam is such a phenomenal figure. Madam's passion to the subject, be it for the patient care or for the academic activities or for research, is unparalleled. And I'm very grateful that Madam has, she was my own teacher, and I've worked with Madam for a long time. Madam, to inaugurate actually this NutriLearn series for this year, because last year Dr. Priya was doing it very well. I think with that, I'm just thank you all for being here. All of the people who have joined here, my friends and all the students. I now hand over to, I request Dr. Nandakumar sir to make the presidential address. And Jeetu will be comparing this session.
Yeah, good evening, Dr. Geeta, the chairperson, nutrition chapter, and most respected, the mother of nutrition, Elizabeth Madam, and Dr. Jose, also vice president, and today's speaker, Dr. Gopika, and other dignitaries on this platform, my dear friends. As a president of IAP Kerala, I am very happy today because we are continuing our Nutrition series. Last year they conducted very well. So that is, as you all know, nutrition is one of the most important part that differentiate pediatrics from other area of medicine. So for any pediatrician, whether they are PGs or practicing pediatricians or they are academic teaching any side of, so nutrition is one of the most important thing. So in practice, as a practitioner, the nutrition in coming years, the infectious diseases are coming down. So we have to concentrate more on nutrition part and well-baby clinics. So as a part of this, I request all to join regularly for this Nutrilearn series. And Madam I really thank Madam for sparing the time to inaugurate all those things. And Madam will be looking after this series well. And I wish all the very best for this series. And over to Dr. Geeta.
Thank you, Nandakumar sir, for that inspiring words. Next, we have the formal inauguration of the Nutrilearn series. It's the pride and privilege of Nutrition Chapter IAP Kerala. We are honored by the presence of none other than Dr. K. Elizabeth to inaugurate the Nutrilearn series. I had put some words about Madam, but Nandakumar sir has already called Madam as the mother of nutrition. So going with the trend, I think I can call her the Sarvam Nutrition of the mother of the Sarvam Nutrition in Kerala. So I welcome, it's my honor to welcome Elizabeth Madam to inaugurate the Nutrilearn Series 2026. Madam.
I think you can call Dr. Jose to speak, our South Zone VP.
So I have great pleasure in inviting Dr. Jose, Vice President, South Zone CIAP, to deliver the keynote address.
Thank you, Dr. Geeta. Is audible? Is I am audible?
Yeah, audible.
Yes.
Thank you, Dr. Geeta. Respected IAP Kerala State President Dr. Nandakumar, the mother of nutrition, as Nandakumar mentioned, Dr. Elizabeth Madam, going to inaugurate this program, and our Nutrition Chapter Chairperson Dr. Geeta, Secretary Dr. Geetu, and our State Secretary Dr. Bobby Mohan, and all the past President of IAP Kerala, like Dr. Parvati Madam, Dr. Santosh sir, and senior faculty like IAP member like Dr. Patani sir. And good evening to all. First of all, I wish you Happy New Year to all of you. As you know, the nutrition Dr. Nandakumar mentioned is a very important aspect of a pediatrician or postgraduate student is concerned. As you know, India is facing dual burden of nutrition like malnutrition and malnutrition in the form of obesity, and some are the two important spectrum of nutrition aspect is concerned. As you know, the obesity is increasing the day by in our community due to the lifestyle disease and other feeding habits. In the other side is we are now facing the malnutrition in the form of mom and Sam, that making a lot of morbidity in the under 5 children is concerned. To update in the knowledge and nutrition chapters doing a wonderful job in the various last few years. Nutrition chapter under list of Dr. Elizabeth Madam and all the nutrition leaders in the chapter conducting a very good action plan for last 7 years. First of all, I wish you all the best. Again, I take the opportunity to congratulate our own mother of nutrition and IAP Kerala. Very proud to say that this year none other than our Elizabeth Madam going to give our prestigious Central IAP oration, the oration this year. I think the opportunity to congratulate Dr. Elizabeth Madam. We are proud of you. I think this is the third oration from IAP Kerala, conducting national oration by after N.K. sir and Sekhar sir, and again our Elizabeth Madam going to give oration this along with the Pedicon 2026 conference. I request all the faculties and delegates that attended the Pedicon 2026 at Calcutta to be there to witness our prestigious oration of Central IAP and done by Dr. Elizabeth Madam. And it is a very prestigious moment for us, a Vice President. I am get honored that Elizabeth Madam is the orator for Central IAP. Again, I request all of you to be there along with that Elizabeth Madam oration. Another important activity coming this Pedicon. We are going to IAP Kerala, going to receive a lot of our Central IAP Kerala state level, and our more than 10 branches of IAP Kerala going to receive the award from Central IAP this year. So it is a received moment of IAP Kerala again for all of us. And of course, all of you there in the award ceremony, and along with a lot of faculties. I go to the faculty list, more than 25 faculties from Kerala is there. So I request all of you there, our witness, our faculties are giving the talk in the national level. And again, as a president of vice president of South Zone, I request your wholehearted support for one year for activities of South Zone is concerned. This year's Central IAP action plan is already rolled out in the history of IAP. The day one itself, already the Central IAP action was allotted to more than 10 branches of IAP Kerala. It is also honor for IAP Kerala in the national activities concerns. With these dates, I conclude my talk. I wish you all the best this nutrition CME program, and wish you all the best program. I again congratulate Dr. Nandagumar and team for incoming 1 year with excellent activities in coming year. Jai Hind, Jai Hind.
Thank you, sir, for this inspiring talk. Ma'am, Elizabeth Madam.
Okay. Good evening, and thank you very much, Dr. Jidu. I'm so happy to see all our stalwarts and captains here. Dr. Jose, South Zone VP, Dr. Nandagumar, State President, Dr. Sunu, Vice President, Dr. Parvati Ma'am, Senior IAPN, Dr. Gopika, Trivandrum President. I think so. All officials and seniors and friends. Dr. Patani sir also, the senior most. Dr. Sindhu is here. She is president of the IYCF chapter of Kerala. So Patani sir was one of our senior participants of the 6 months course we had, and his logbook has been chosen as a model and was shown during it is shown every batch. So we are so proud that sir's commitment and the way he went along with the course and came out in flying colors. So we were telling that before COVID, actually nutrition was taking a backseat ride. All other specialities got into front seat, but nutrition was pushed back. But after COVID, I really saw that lot of interest was created. During COVID, we had a lot of Zoom meetings, and people were very much interested in their own health and in the health of the children. And that is how nutrition came up. And I am very happy that in 2016, when I was Kerala president of IAP Kerala, I said we must have a crusade against malnutrition. And it is not only undernutrition, it is also the overweight and obesity. Both are to be addressed at a war footing. So I proposed a 6-step approach, A, B, C, D, E, F, and then continued growth and developmental surveillance. I'm very happy that Dr. Gopika took it up. And when we were having the NIOP, that is Nutrition in Office Practice during Pedicon, Kerala Pedicon 2025, we had a workshop, and Gopika was presenting this 6 steps, what I proposed. And I was very happy. And as a student and a postgraduate of mine, Gopika, and now we are together in Anantapuri Hospital as a colleague also. I'm feeling very proud of her that she is showing keen interest in this thing. And also, I must say that Dr. Geeta and Dr. Jeetu, as students and as postgraduates and as clinicians and pediatricians, they are also very much interested in nutrition. And Priya started this NutriLearn and took it to great heights. And I'm very happy that Dr. Geeta is continuing the NutriLearn. And she wanted me to do the first session. Then I said I'll chair the session, and I only proposed that Gopika do this 6-step approach. So that is the background of this. We have great responsibility to our children and the children of the nation that they should have normal health. Normal children also do need nutrition advice, developmental surveillance. That is what we have to think. In the last many years of my service, people ask me what is the greatest challenge in nutrition. I'll say the normal children are shrinking. We are seeing the overweight and the obese children more number, and undernutrition, underweight, because the nice NICU survivors, if they don't get proper feeding, they also continue to add to the pool of malnutrition. So malnutrition is increasing on either side. And then what is happening is that micronutrient malnutrition is also so much on the rise. So with this background, I'm very happy to be part of this first learning session of NutriLearn under the leadership of Dr. Geeta and Dr. Jeetu and Dr. Nandakumar and Dr. Jose and all the stalwarts here. So I bless this occasion, and I am very happy to declare this inaugurated, and wish you happy learning throughout this whole year. 12 sessions Dr. Geeta is planning to do. Great effort. Congratulations and all my blessings. Thank you very much. And I'm also thankful to Central IAP for bestowing that award on me. I'm getting a little nervous, but with all your blessings, I hope I'll be able to do it. Thank you very much.
Thank you, madam, for this kind and inspiring words. Next, I invite Dr. Joseph Patani, sir, a senior IAPN, to felicitate the gathering.
Oh, thank you for the invitation. Actually, I was not expecting to talk anything. I'm an old student. I mean, junior most student of this batch, probably. But I like to. Today only I saw the WhatsApp in about this talk, so I postponed my practice. In fact, I have a few patients come the event. I told them to not come, and I'm happy that this Nandakumar has initiated. As usual, he is very active, and Gopika and Neetu. I was not knowing you are Neetu. Actually, I forgot about your face cut. I'm happy that we are going, because as madam said, actually nutrition part, actually both undernutrition and malnutrition goes in different ways actually, and the normal children also is not caring him. So we in fact in our Kottayam district actually obesity is far increasing, and normal children are shrinking actually. Madam said exactly actually. So we have to find a way as pediatrician, and I think and this all this talks will go to that level. I wish all the best for this talk. Thank you. Thank you very much. Thank you very much for calling me also. Thank you.
Thank you, sir. Next, I call upon Dr. Gopi Mohan, sir, Secretary IAP Kerala, to share his felicitations.
Madam, President Dr. Nanduma, South Zone Vice President Joseph, Elspeth Madam, other dignitaries, seniors and friends. I would not like to take much of a time. Everything is already covered by the people before me. Would like to congratulate Elizabeth Madam, who's going to give the prestigious Dr. Seth oration now in Pedicon. It's a real proud moment for us. Last year, Priya and Sajida did a very good job with Nutritalk, and I'm very happy that Madam and Jeetu is taking off from where they left off. I wish them the very best and wish you all happy learning. Thank you. Jai Hind and Jai Hind.
Thank you, sir. With that, we are moving on to the scientific session. I request Dr. Geeta Madam to kindly introduce today's speaker.
Thank you, Jeetu. It's with great happiness that I'm welcoming Dr. Gopika Sekhar, a reputed senior pediatrician from Trivandrum, from the Anandapuri hospitals, for this inaugural session on the important topic, as all the previous speakers have said, the malnutrition, that is a both ends. So the topic is paradox of malnutrition, the SAM and obesity in office practice. She's very friendly, patient-friendly pediatrician, and she is known for her excellent clinical acumen. She is an alumnus of Government Medical College Trivandrum and SAT hospitals, and I have known her since her student period. And it's with great pleasure that I welcome Dr. Gopika for the inaugural session. Please, Dr. Gopika.
Thank you, Madam. Respected State President IAP Kerala, Nandakumar Sir, Secretary Gobi Mohan, then Nutrition Chapter Chairperson Geeta Madam, my teacher, and Jeetu George, then my most mentor and my teacher, Doyen of Nutrition, Elizabeth Madam. I feel honored that I am invited for the inaugural session. I take this opportunity, especially thank Geeta Madam and Elizabeth Madam for giving me this opportunity. And with this, I will start my presentation. Madam, screen share host disabled എന്ന് കാണിക്കുന്നു. Madam?
അത് ഡോക്ടർ ഗോപി അത് കോ ഹോസ്റ്റ് ആക്കാൻ പറ്റൂലേ? ആക്കണം.
Dr. Jitu, can you make Geeta Madam co-host?
എന്നെയല്ല, ഗോപിക. Jitu, please make Gopika.
Okay, Gopika. Dr. Gopika co-host. Then she can upload.
Okay, madam, I have made you co-host.
Madam, can you now see it? Can you see my presentation?
Yes, madam, it's visible.
Okay, കാണാം. Full screen ആക്കിയാ മതി.
Okay. With blessings from Elizabeth Madam, I'll start my presentation. The topic today selected by Madam only is paradox of malnutrition, addressing SAM and obesity in office practice. So, as Madam discussed, why should we do the nutrition assessment? Because we have to early detect the cases of undernutrition and overnutrition, and we have to guide them properly by giving proper nutritional advice and prevent the occurrence of micronutrient deficiency even in normal children. And who are the ones who should be looking at, especially pediatricians? We should be the one, and what parameters we should look for, what is the best time we should interfere, and how, once we detect complications, how will we treat? These are the points which I will cover in this presentation. So, as Madam said, the NFHS 4 and 5 survey, it's very dismal. Indian statistics show that, as you see, the wasting, severe wasting and overweight has increased for the last 5 years. And Kerala is also not far behind. We have the statistics show that even stunting, wasting, underweight and overweight, everything is on the rise when comparing with NFHS 4. The present criteria shows that we are sitting on a silent epidemic of undernutrition and obesity. So pediatrician will be the first contact for to assess nutrition. It can be done as very easily if we have a practical checklist. It can be done as an OPD screening procedure. So that will help us to identify growth faltering, any micronutrient deficiency, and thus prevent our children from falling into the pit of undernutrition and obesity. So, as Madam said, this was a 6-step nutrition checklist developed by Madam when she was president of IAP Kerala in 2016. Now, 10 years down the lane, I have taken up this, and we should revamp this 6-step screening checklist. It will be A, B, C, D, E, F. We should not stop with anthropometry alone. So, from anthropometry, we have to do the biochemical, followed by clinical science, and do a dietary assessment, assess the proper environment, and what functional assessment, about what is deficient in them because of this malnutrition effect, followed by a growth surveillance, would be the perfect screening checklist for guiding us through the malnutrition. So anthropometry. So you know that all the ASHA workers, the ICDS staff, Anganwadi, everyone is taking the weight. And we should not stop with weight alone. We should go for the length, less than 2 years, and height for more than 2 years. We should measure their head circumference, then the mid-upper arm circumference, and plot them in weight for height in less than 5 years and BMI in 5 to 18 years. Why? Because in nutritional deficiency, weight deficit is a manifestation of acute malnutrition, but chronic malnutrition, height is affected more. So we have many charts. As postgraduates, we'll see when we have centile charts, Z-score charts. So which one should be used? Centile charts, actually, it is useful for routine growth monitoring. But if the child is in the extremes, that is either underweight or obese or overweight, these charts do not quantify the severity. So if we find that the child is falling below the reference standards, that is below 3rd or above 97, we should plot them in the Z-score chart. It is useful for diagnosing and grading malnutrition because it is accurate at extremes. So because I am dealing with SAM and obesity, I will be using the Z-score charts in this presentation. Now, as everyone know, now it is the digital era. So we have a growth chart plotter that is developed by Dr. Peter P. Varayil, a senior IAP member. So we can move you can easily do it with your mobile phone. All of you can download this growth chart plotter very easy, and it can be plotted at bedside. It has percentile charts as well as Z-score charts. And now we'll go for each one individually. Weight measurement. Weight measurement, as you can be easily done using a beam scale. If the baby is very small, but if the child is crying, you can do tarred weighing. That is, you can take the weight of mother and baby together and then reduce the weight of the mother from that. Or you can weigh the child on a digital scale. Then on all Z-score charts, +2 to -2 is normal. Less than -2 is underweight, and when you plot the weight for age in this thing, -2 to -3 becomes moderately underweight, and less than -3 is severely underweight. This should be charted according to the Z-score chart. Similarly, you can measure the length. Length, everyone knows the recumbent length that is measured in the infantometer. Here, the infantometer, as you know, there will be a fixed head part that you can ask the parent to hold, and you have to straighten the knees and bring the foot end of the infantometer towards so that it touches the sole of the baby and measure the length. If the child can stand, you can measure the standing height, but you have to be careful. You have to see that the sole, the buttocks, the scapula, and the occiput should touch the wall. And the child should be looking straight forwards, and you should be in the measurement, you should be at the eye length. The eye contact should be without any parallax error. Here also, the score +2 to -2 is normal, and more than +2 shows tallness, and less than -2 standing. If it is -2 to -3, it is moderate standing, and less than -3 means severe standing. Next comes the head circumference. Head circumference, you can measure it using a non-stretchable tape, and it marked most two prominents are important: the occipital protuberance and the supraorbital ridges on the forehead. Because only if you do that, you will get the maximum circumference, and you have to do it by the overlap technique, and that is seen in the picture. So here also, less than -2 means moderate microcephaly, less than -3 is severe, and more than +2 is macrocephaly. But this is said to be the most sensitive indicator of prolonged malnutrition, and it will definitely shows intellectual impairment and poor cognitive development. Next comes the MUAC. MUAC usually we do it to 6 to 50. And the classification is more than 13.5 centimeter is normal. 12.5 to 13.5 is at risk, and we have to act immediately. 11.5 to 12.5 is diagnosed as MAM, moderate acute malnutrition, and less than 11.5 is SAM, severe acute malnutrition. The thing with MUAC, it is an indicator of mortality. That is, the risk of dying is more when you see that MUAC is less than 11.5. But we cannot use it to monitor growth because it will be a slow, the change in trend is a very slow process in case of MOVAC. So once you have plotted the weight and height, you can plot it in the weight for height and then the graph, and then you can know that whether the child has wasting or overweight. Here also, as I said, all these Z-score charts, +2 is to -2 is normal, less than -2 is wasting, and -2 to -3 is MAM, and less than -3 is SAM. +2 to +3 will be overweight, and more than +3 is obesity. So we have, as I said, we are discussing MAM and SAM. So now we have come to the weight for length chart. And in that case, any one of the following, we have to see how we can diagnose MAM. So any one of the following, that is important. In MAM, if the weight for height is between -2 to -3 or MOVAC between 11.5 to 12.5 centimeter. Similarly, for SAM, 6 to 59 months, if the weight for height is less than -3, or there is bilateral pitting pedal edema, or MOVAC less than 11.5 centimeter, the child is diagnosed as SAM. If the length of the child is less than 66 centimeter, we have cut down the MOVAC criteria to less than 11 centimeter. 6 weeks to 6 months, SAM is diagnosed by either the weight for length as usual as -3 is Z-score, or if the weight is less than 70%. That if the length is more than 45 centimeter. Suppose the length is less than 45 centimeter, the visible wasting, that is wasting visible to the eye, is enough to classify as SAM. Here also, either bilateral pitting pedal edema or MOVAC less than 11 centimeter is said to fit in with the criteria of SAM. You should know that any one of the following is important for diagnosing MAM and SAM. So this, as I said, this can also be plotted in the digital chart by Dr. Peter P. Varil. And you can just plot the age and you can, the date of birth, the length of the child and the weight, and it will automatically plot and you will get that it is diagnosed. See, when you chart the weight of the child and height, it will come as it is between -2 and -3, diagnosing it as MAM. It's a very useful, friendly app. So suppose here we are discussing obesity. In obesity, the weight for height, if it is less than 5 years, we should plot it, as I said, in the Z-score chart for weight for height. But if it is more than 5 years, we can go for the BMI chart developed by IAP. So here you can see the orange line that shows overweight. It is equivalent to the 23rd adult. These are not centiles. The 23rd adult equivalent, that shows overweight, and the 27th adult equivalent shows obesity. So now combining all this, we have now a pediatrician friendly growth chart. That is this graph. Here a single graph is integrating WHO and IAP growth references. It is adapted for Indian children and it allows simultaneous detection of underweight, stunting and obesity. And you can also plot the mid-parental height in this. And the upper curves for BMI for obesity are also seen very clearly. Here also the yellow line corresponds to overweight and the orange line obesity. The only drawback of this that here also it is more suited for more than 5 years. In the less than 5 years, there is a little crowding and it is difficult to plot in this graph. This also is available in that digital this app, and we can very easily plot over. The trends can also be seen. If it is 2 times, if we plot the weight, and it will come automatically, and we can see the child is going in becoming overweight. The child's weight BMI has changed from overweight to is going in an upward trend. So why plotting is important? Because it tells whether the child is growing normally. And for at-risk population, that is children with abnormal values, we can see whether the child is becoming normal or with the child when the child crosses a major Z-score line, or if it's crossing to major centile curves, whether there is a decline or incline in the curve, whether the curve is flattening. All these can be known only when we plot it on a graph. See, I'll see these MCP charts. Here we'll see, suppose at the first look, if we are plotting, we'll see that the 3rd and the 4th child, they are having malnutrition. But if we see the graph, we see it is a normal growth trajectory. They started with a low birth weight and they are growing normally. They are picking up their weight and they are going in the growth trajectory is important. So it is a normal growth trajectory. So this shows that all these children, 4 children, are growing normally. And what about this graph? Here we see that they have the red line. They have started off with a low birth weight, but the growth has stopped. It is a flat line. So this child we should monitor. This is the importance of plotting of growth trajectory. The trend shows that the child is crossing down centiles, and he should be correction should be done at this stage itself. And what about this? This shows that there is a sharp incline in the growth curve, showing that the child is crossing centiles and the child is gaining weight, and the child is going to be overweight and obese. So not only measuring this thing, but also plotting is also very important. This can also be done in this app. See, here we can plot the growth velocity at 2 times, and then we can see that this graph beautifully tells that this growth velocity is less. And for growth velocity, this thing we should use that more than 25th centile is normal, but less than 10th centile. It is not the 3rd centile. For growth velocity, 25th centile is normal. And if it is less than 10th centile, we should be concerned. So when will we do it? That is always a problem in a busy OPD. But you should know that we have 11 wellness visits. Usually, after once a child baby discharges, it will come back on the 7th day. Then at 6, 10, and 14 weeks for the normal immunization. And we can call them back at 6 months. And we can advise them regarding the complementary feeding, as well as measure their weight, length, and mid head circumference and move up. Now, again, 9 months, they will come for vaccination. And after that, after 1 year, we should call them back at 6 months. Every 6 months interval is enough to monitor the weight, length, and the head circumference. Also, in case if they are having some short febrile illness, when there's some follow-up visits after recouping from sickness, you can do the anthropometric assessment as well as follow them up. If the child is in mid-childhood and adolescence, that is at 4 to years, height and weight may be monitored only once in 6 months. More than 6 years, you should also measure the penile length and SMR also. And after 9 years, you do it yearly is enough. SMR among adolescents, now the new staging is designed as girls, the breast size and contour is graded from B1 to B5, and boys also it is graded as gonadal size G1 to G5, plus the pubic hair P1 to P5 in both sexes. Now we have finished with the anthropometry. So one thing I have to say that we should not stop with the weight alone. Please check the length of the child, the height of the child, and the head circumference and the mid upper arm circumference. Plot it on graphs and see whether the child is growing normally, whether the child is crossing or their centiles down or up, and interfere at the correct time. Now, we have detected malnutrition. We want to know whether there is any infection. So for that, we'll do for a complete hemogram. Then whether there is any micronutrient deficiency, we'll look for the red cell indices. Then you have to see urine analysis for there any chronic illness, stool examination for the cause of any parasites, any chronic malabsorption, blood in stools, renal function for chronic renal diseases, and liver function test, fasting glucose, lipid profile for obesity. That is, it's to rule out metabolic syndrome, we have to do the HbA1c, the lipid profile, liver function test, etc. Now, once we have done with this, we can look at the child, the clinical signs and symptoms. You should give importance to signs of malnutrition, like lusterless, thin, sparse hair. Also, other signs of micronutrient deficiency, like B12 deficiency, vitamin A deficiency, like white out spots, conjunctival dryness, any chelosis, stomatitis, then calcium deficiency, any vitamin D, C deficiency. Look at the child from head to foot. Along with that, you can also look for the if there is edema, you have to grade the edema of SAM, because if it is mild edema, that is edema both feet and ankles only, it is uncomplicated SAM. But if the edema is moderate, that is it extending up to the lower legs or hands, or if there is generalized edema, it becomes complicated SAM. Similarly, other complications you should look for in clinically, that is in your clinical assessment, you see a child of SAM you diagnose her as SAM, you have to see whether the child is having appetite, whether it is the child is without appetite, whether the child is lethargic or unconscious, whether there is any danger signs like signs of hypoglycemia, hypothermia, high fever, febrile convulsions, anything, or the edema, as I said earlier, whether the child is having any infections of like pneumonia, diarrhea, severe dehydration, sepsis, septic shock, whether child is showing signs of micronutrient deficiency, anemia, or skin changes of vitamin A deficiency, then with the persistent diarrhea, and if any complications, these are the complications we expect. If there are any complications, you refer them to a nutritional rehabilitation center and get them admitted as IAP. But if the child is without complications, age is more than 6 months, and you have a confident caregiver, you can be confident, you can be cool. This child can be managed as an OP practice. That is community management of acute malnutrition. Now, but suppose we are seeing after this assessment biochemically and clinically, we are seeing a patient, the child is overweight or obesity. What else we should do? We should look for the blood pressure. We should screen for hypertension. We should see whether the child is having signs of insulin resistance like acanthosis nigricans. And not only BMI, you have to look for the waist circumference of the child, because it is a better predictor of visceral adipose tissue, and it predicts more with it correlates more with the risk of metabolic syndrome. And look for hirsutism, acne, look for evidence of snoring, sleep apnea, ask the history, and most important, look for any dysmorphism or short stature. Why? Because, and that I will come in the next slides. Now, acanthosis nigricans, you can grade it as, if it is prominent only on close visual inspection, then it is only, you can just say it is present. If it is limited to the back of the skull or base of the skull only, it is mild. If it is extending to the lateral margins also, it is moderate, and severe means extending round the neck. Now, waist circumference, now as previously, now there are waist circumference specific age and specific charts are available. So for waist circumference, we take the 70th percentile as the cutoff for central obesity in Indian children. And we have children where BMI can be normal or even low, but high waist circumference, which shows that they have more chance of metabolic syndrome. Previously, I said that a short stature is very important. Why? Because obesity, there are, we have to classify obesity. Once we diagnose as clinically obesity, whether the child is having short stature, developmental delay or dysmorphism, whether there is any drug history, or the child is having normal growth. So if the child is having facies, abnormal facies, or the moon face, any dysmorphism in the fingers, hands, feet, etc., then you have to rule out endocrine causes or syndromic causes of obesity, like Lawrence-Boone-Biddle or Cushing syndrome, pseudo-hypoparathyroidism, hypothyroidism, etc. But if the height, that is most important, if the height and weight are both on the upper centiles, then it is exogenous obesity. And as a rule, more than 90% cases of obesity will be exogenous. Only 10% contribute to the endocrine and syndromic causes. So now we have diagnosed the child with the SAM. We have ruled out the complications clinically. We have, or if it is an obese child, we have classified it as exogenous obesity. Now what do we do? First, I will start with a normal dietary assessment for a normal healthy child. For a normal child, breastfeeding infant, you have to do the 24-hour recall. Ask them about the breastfeeding practices, complementary feeding practices. Then you have to ask whether the child is getting minimum dietary diversity, whether the child is taking 5 out of the 8 food groups, including breast milk, and whether the child is having a healthy eating plate, whether the child is having whether the child is getting enough fruits, vegetables, fibers, vitamin A rich foods, etc. Now, if it is a SAM or MAM, usually the Holiday and Sekhar formula for fluid calculation is based on the ideal weight for age. But in SAM and MAM, you should know that the present weight, whatever the weight of the child, is used for calculations. And the bedside calculation of energy is for the 1 year, you give 1000 kilocalories. Then for the second year, you add 200. From then on till puberty, you add 100 kilocalories. Along with that, you can assess the micronutrient sufficiency by asking about the compliance to biannual vitamin A supplementation, as well as iron and folic acid supplementation bi-weekly. And done with this done, you know that if the child is deficient in hidden hunger, there will be poor diet quality, along with that micronutrient deficiency. And as Madam correctly told, that early undernutrition, our preterms, NICU survivors, they have a metabolic programming as described by Barker hypothesis, which in turn can lead them to rapid weight gain. So suppose that our child is SAM without medical complications. The first and foremost is what we have to do is we have to document an appetite test pass for SAM. So what is this appetite test? So first, most important is you have to explain to the caregiver how to do an appetite test. So then you have to say, you have to instruct them to wash the hands and take proper hygienic measures and make the mother and the child sit in a quiet corner and ask the caregiver to offer ready-to-use supplementary food, gently, patiently encouraging the child. Tell them it may take up to 1 hour. Never force feed the child. And you have to ask them to plenty of water to drink along with this RUSF. So if the child passes this appetite test, if the child is eating RUSF, and then you can say the child can be managed as OP. If it fails appetite test, even if the child is not without complications, you have to go for IP care. So what is this RUSF? So RUTF, that is ready-to-use therapeutic food, is a peanut-based paste supplied by UNICEF, but it is not endorsed by the government of India. So we have to make our own RUTF, that is ready-to-use supplementary food. It is used for more than 6 months. For less than 6 months, we have to use high-cal milk powders, which is available. So this is a lipid-rich, water-soluble, high-energy protein food. It is indigenously prepared, but it is ready to eat at home without cooking. It can be given for the child for 6 weeks to 3 months. So indigenous preparation is, you can mix SAT mix, which is a rice, wheat plus black gram mixture in the proportion of 3:1:1. That is 3 portions of SAT mix with the skimmed milk powder plus coconut oil. The skimmed milk powder is one of the you can use as a Amul's Sagar. That is, it provides 36 gram proteins. And because we can't fortify it with the micronutrients, we have to give them micronutrients extra. Another is we can use ESAM, which is a commercial cereal pulse mix. You can mix ESAM with the skimmed milk powder and coconut oil in the 3:1:1 ratio, and you can make your own RUSF. So what should be your feeding plan? You have to aim at an home-based diet which provides 150 to 180 kilocalories, which can be provided by the RUSF. Then you have to feed at least 5 times a day. As I said, you have to supplement the micronutrients, vitamin A, folic acid, zinc. And even if there is no evidence of infection, you should give amoxicillin. It's the preferred antibiotic for subclinical infection. And enforce on deworming also. So suppose the child is having obesity, what will be your diet plan? You should enforce on this 50:25:25 rule. That is, the child should be given a diet which is rich in fiber, 50% provided by vegetables and fruits, and protein 25%, and less than 25% carbs, and of which it should be smart grains with low glycemic index. Fats should be given only in moderation because it will prolong the satiety and they will be able to take less food. So you have come across, as I've said, the 6 steps. Infection. We have done lab investigations, assessed them clinically. We have prescribed their diet plan. Now comes the most important part, that is environmental assessment. Environmental assessment we can divide into physical, biological, psychosocial, and microenvironment. In the physical part, you have to discuss a bit there about their socioeconomic status, that is depending upon their education, their occupation, their income. That is, then only you can get a confident caregiver. You should know their educational status, whether they are APL or below poverty line or above poverty line. Then the sanitary conditions based on Briscoe scale. That is, whether they have a pipe water or it is well water, about their sanitation facilities, whether it's a pit latrine or they have bathroom facilities, what about their hygienic practices after sanitation. Most important is their water storage facility. Then it is said that you look at the mother's clothes, whether they have washing facility, whether there is chance of infection. Then the housing conditions. Housing conditions include mainly whether there is electricity or recreational facilities. That is, it will give us an idea of how we can counsel the mother. Then health of other family members, whether there are other sick children, sick members in the family. Then cultural values. With prescribing the diet, we should know their cultural values, their habits, customs, their religion, what foods they take, what foods they do not take, their lifestyle, their attitude towards practices, etc. And most important is the microenvironment. That is the family harmony. Whether the mother will be able to look after the child, whether the mother is blaming herself for this condition of the child, whether mother is being blamed, whether there are any supportive family members, friendly neighbors, or a supportive husband to help her in child rearing, whether she's happy with herself or she's not uncomfortable, then she will find problem. She will not be able to bring her up child properly. She will not be comfortable with the confident in this when we prescribe these dietary practices to her. So family harmony is most important. Whether she's neglecting the child, whether she has another sick child at home, whether she can give sufficient time to look after this child, all this comes very important. We can't just prescribe a diet and send them home. That will not work. We have to sit with them, assess their environment, whether they will be able to carry out this at home, and then only we can send them home. That is the importance of environmental assessment comes in caregiver counseling. You should know that they understand what we mean by frequent feeding of thick energy, dense foods. What is the importance of this? What is the condition of our child now? When will we expect a change in this her weight? Everything we have to counsel her. Then most important is hygiene and hand washing. And then you have to educate them about the danger signs, whether if the child is not feeding properly, if the edema is increasing, if the child is having fast breathing fever, all these things, you have to bring the child. And when we should refer the child to an IP facility, that also we should be knowing. Now, if it is obesity, the situation is different. You should take into confidence the whole family. And you should always set achievable goals for the child. That is, always aim for weight maintenance in children less than 6 years, and only dietary restriction in children above 6 years. Then you have to motivate the whole family to a disciplined diet. If the father is always snacking, then our diet will not work. And you should see the whole family move to a definite exercise pattern and a proper sleep hygiene. And you have to clear the misconceptions about body image also. And you have to identify a partner for exercising with the child. You have to explain the complications and dangers of obesity to both the parents, and nowadays especially to the grandparents, because the grandparents will be looking after the child, and point out the fallacies in their current lifestyle now, and what should be exercise should be prescribed as a prescription. And you should encourage them to take breakfast, regular meal times, a mindful eating in a gadget-free zone, and also advise them regarding portion control. So the children, if they are adolescents, you can advise them to read the nutrition labels of the foods, junks they are eating. And as a rule of thumb, it is said that you have to decrease the nutrients, that is like sodium, etc., which we do not prefer. Take those junks which have these contents less than 5%, and the nutrients that we need, like fibers, carbohydrates, etc., it should be at least more than 20%. Trans fats and sodium less than 5%, and fibers and carbohydrate more than 20%. Please take junk foods with after reading the nutrition label is the advice we should give to the adolescents. So now we have counseled the caregiver. Now we have to, when we follow up them, we have to do a functional assessment, whether this malnutrition has affected their development, their vision, hearing, whether they are suffering from any gross motor delay because of the muscle weakness, if they have having micronutrient deficiency like iron, whether they are tired all the time, whether they have calcium or vitamin deficiency, skin changes, and for overweight children, about their physical activity, screen time, then whether they are having any other coexisting morbidities like hyperactivity, all this will become under the functional assessment, and this we do in our follow-up. Along with that, we have to do their developmental assessment also, whether they have their developmental abnormality, whether their developmental milestones have been affected by this malnutrition. So, considering this A, B, C, D, E, and F, we'll do a weekly follow-up of these patients. And if it is SAM, we have to expect a weight gain of at least more than 5 to 10 gram per kg per day, with an increase in MOAC and resolving of edema, improving appetite. And we tell that they have recovered when their weight or height has crossed the -2 Z score, MOAC is more than 12.5 centimeter, with no edema, pitting edema for 2 weeks, and they are clinically well, active and feeding well. So, in a gist, I will say the uncomplicated SAM, once you have assessed the anthropometry, you have did the biochemical assessment, you have done the clinical signs and symptoms, they are diagnosed as uncomplicated SAM, do the appetite test first. If they pass the appetite test, you can confidently treat them as an OP thesis, along with the medical treatment for subclinical infections, with a very good caregiver counseling after assessing their environment, followed by their functional assessment, follow-up, and regular monitoring. And you should also be aware of when we should refer them back to IP setup if they fail our therapeutic measures. So, in the case of, if it is an obesity, as I said, that now the new concept is about white adipose tissue. It is functioning as an active endocrine hormone, so endocrine organ secreting many adipokines. So the hormonal regulation in appetite is through leptin, adiponectin, which decreases the appetite and improve energy expenditure and produce satiety. But if the fat tissue deposition is more, the adipokines produced will change to TNF-alpha, and that will produce a state of chronic inflammation, which brings about the insulin resistance. So what all said and done, dietary modification counseling will not work. We'll have to do exercise, lifestyle changes, as well as cognitive behavioral therapy, because it is said that only when this white adipose tissue changes to brown, thermogenesis, then only our obesity will resolve. So the most important part is not prescribing diet and counseling. Along with that, we have to bring in a lifestyle change and cognitive behavioral therapy. Pharmacotherapy should be the last resort. So what all exercise? It is said that physical activity, we should do at least 1 hour of moderate to vigorous physical activity, that to 4 days per week. Physical activity should be given equal importance for an overweight or an obese child. And the physical activity related behavioral modification should be, you have to limit the screen time to less than 2 hours per day for less than 2 years, and for more than 2 years, and no screen time at all for less than 2-year children. So what is cognitive therapy? It is all or none thinking. That is, suppose they have taken some snacks in between. You should not say that they have deviated from their behavior modification. That is, let us say, okay, it's enough, let us move on. And you can celebrate short-term wins. That is, if they are going free of snacks for 3 days, we should congratulate them and appreciate them. Then you have to always, one thing we always explain to them is you have to disconnect food from reward justification. That is, when they do something good, don't reward them with a chocolate. And you have to teach the child, you have to ask the mother to teach child to wait for 10 minutes before they acting on a craving any snacks or any pizzas or ice creams like that. And the eating zone should always be gadget free. It should be mindful eating. They should know the food what they are eating. They should sit on the table at the fixed time. They should know the chew the food properly and eat. And always remove the trigger foods like the high calorie junks from home environment. And they should have if adolescent, they should do self-monitoring also. So what all said and done, the prevention is always better than treating obesity and SAD. The prevention strategy should start from primordial prevention. You should aim at healthy weight gain for the mother during second and third trimester, and once so that the child will get an ideal birth weight, which is always Madam says is the best gift a mother can give to a baby. Then you should follow the optimal IVCF practices like breastfeeding, start complementary feeding at 6 months, and walk them safely through the complementary practices, and at 2 years of age, they should switch to solid diet, eating all types of foods, the 5 food groups from the food groups, and include the breakfast, dinner, and lunch and dinner, along with the two healthy snacks. Then that is, their diet should be balanced with the micronutrient adequacy. And once they have a healthy diet practice, as pediatrician, we should track their anthropometry as well as body mass index, and especially, as we said, small for gestational babies, NICU graduates, or those with the family history of obesity, we should track their BMI more closely. And from very early age onwards, you have to encourage physical activity and insist on 0 screen time, as I said, up to 2 years of age, and less than 2 hours in older children. And everything should be based on as a single family, school, and community-based interventions. We should include the whole family consider the family as a unit, and change their own environment and their own practice towards food practices, as well as active living style practices. So what I covered is that malnutrition, we are sitting on an iceberg. It is a huge burden, both undernutrition and overnutrition. We have just discussed about the SAM and overweight and obesity. And 6 steps that we can quickly practice is first we have to do assessment by screening by anthropometry, then check their blood, necessary lab investigation biochemically. Then you do a clinical assessment. You assess the child's diet, what all changes we can bring in their lifestyle practices. Then assess their environment, give the caregiver counseling, and do a functional assessment. Then you do manage the nutrition as well as the disease burden. Assess the health problems, whether they are having undernutrition or overnutrition or micronutrient deficiency. You provide health care, you provide nutrition education, as well as monitor them for follow-up and see if they develop any danger signs or any decline, or whether their growth trajectory is following normally, so that they will have a healthy growth pattern. With these words, I stop my presentation here. Thank you for all my senior teachers and colleagues for the patient listening. I also use this opportunity once more to thank Elizabeth Madam, Geeta Madam, and the Nutrition chapter for giving me this opportunity. Thank you.
Thank you, Dr. Gopika Madam, for this insightful talk. I invite Elizabeth Madam to offer her valuable comments on the topic.
Congratulations, Dr. Gopika, for a very power-packed, very comprehensive presentation. I remember her as a postgraduate presenting a social pediatrics topic long time back. Do you remember community pediatrics topic when you were a postgraduate student? That time we really all in SAT, we all appreciated her for that wonderful presentation on social pediatrics, national programs, etc. So now she has done a great job. And whatever was in my mind, she only translated it. She painted it in front of you. I'm very thankful for that. And a lot of some few comments were there. I tried to answer some of them. I think still I will request Dr. Gopika to tell about the screen time, because there is a question like that, screen time for different age groups. When we say no screen for less than 2 years, it is said that we can have a video call with the dad or mom who is away, or with grandparents, and co-watching is also possible. Maybe a nursery rhyme. The mother or the caretaker should also be there. The child should not be left alone. Then no interaction will happen, no? nursery rhymes, pronunciation, and all. Many children pick up from these cartoons and some screen, but it should be limited and there should be supervision. That is it. And then the rest of it, I think Gopika has a slide. You can tell that. That is till 2 years, no screen time.
No screen
Even though
time.
that we say that co-watching video calls, because they should know grandparents, parents may be abroad, so they have to have some co-watching. After 2 hours, after 2 years, 1 hour. And then in school going children, 2 hours we say, but the issue is that now they have academic screen time and non-academic screen time. So we only calculate the non-academic screen time. We should take into account the academic screen time also, because their tuition is online. Most of their assignments come online. So I am telling that they should have green time. Everybody should have green time. Okay, Gopika can continue.
And one thing we have to think that the screen time, it is not, should be not for feeding purpose. They should not see that screen and or the mobile and watch and eat food. They should be taken to the outside. As madam said, we should provide them green time while we are feeding, and the time for feeding should also be limited. That is, we can allot the specific times. We did not force them food every time and go on 1 hour and 2 hour feeding time. They should know that they will be given food only for half an hour. So whatever they can eat at that time, we should give them. We should not emphasize on to finish the plate, so that whatever we have taken, they should take, and we can continue. Some mothers will come and say there, we have to feed them for 1 hour and all. No, not like that. The child should know that only for 20 minutes or 30 minutes, I will be given food. After that, that plate will be taken off from my table. So then they will, next time when we give them food, they will try to finish the food in half an hour. They will not just go on watching TV, or they will run about and then continue eating.
Thank you, Gopika. It was a real pleasure to listen to you. It was like how madam was teaching us earlier. Very good. And I think today in our now the new postgraduates have joined. Today, actually, I was fortunate that I could take an IAP and first critical window and the growth assessment similar to this, a part of this for them as an introductory class. So, but actually, I forgot that mnemonic ABCDEF. I was telling about all these things. I remember how madam was telling about that buccal mucosa, and also I was telling all those things are not done, but we are doing it functional assessment. But I forgot this ABCDF. I've told most of our students to join. I hope somebody is listening. So it is actually a very important topic, because every pediatrician, or be it not only pediatrician, everybody have to know the basis of nutrition. As madam said, even the normal children need advice, because there is no family support for most of the couples. And you have actually started from basics, and you have actually gone into the whole spectrum, that is malnutrition and the obesity paradox. And very important, as madam was also, you were also telling regarding the growth trajectory, the velocity, and very important regarding the MCP card which you have shown. And I remember how madam was instrumental in bringing out such a beautiful book instead of that old card which we had. But we in teachers, he always say, if we are not doing it, then nobody will do that plotting. That is the sad situation of an MCP card. So at least now we are going all out to plot. Whenever you see a child, you take that MCP card and plot, because early identification, as you said, is very important. The growth trajectory, which you have shown very beautifully, and the velocity of growth. And a very important concept of wellness clinics. Actually, in major government teaching hospitals, we don't give much importance to wellness apart from immunization, because in the busy OP, because we we deal with more sickness. So your concept of wellness clinics will be greatly appreciated by our PGs. That's what I feel. And because as Madam rightly said, normal children we are also not seeing. We are seeing all the babies who are small, growth faltering, or some other issues, probably in utero and all issues, who are surviving. And also the other paradox, most of the children are obese, and we see even small children as young as 5 or 6 years having this acanthosis and all. So thank you, Gopika, for that really very important topic and for starting a kickstart of this Nutrilearn series. Thank you, Jidu.
Thank you, Madam. I think most of the queries that had come up in the chat box has already been answered by Elizabeth Madam and Gopika Madam. So is there any, the topic is open for discussion. If anybody else has to offer any comments, please come up with the same. If no, can we move on to...
Nobody is asking. I think you can formally close.
So now it's time to formally close the session and the time for vote of thanks. All the senior IAPs here, those who have attended the meeting, at the outset, I'd like to thank the IAP team for offering me the opportunity to this prestigious task of being the secretary to the nutrition chapter. I'm especially thankful to Elizabeth Madam, who was my HOD, my mentor, my guide, everything in nutrition, and still a person who I look upon to. So I thank Dr. Elizabeth Madam for inaugurating the series and chairing the session. I thank Dr. Joe Sir, Vice President, South Zone CIAP, who has been a constant source of inspiration for all of us. Dr. Nandakumar Sir, President, IAP Kerala, the spearhead of all the activities. Dr. Gobi Mohan Sir, Secretary, IAP Kerala, for his technical support, organizational and moral support in continuing this Nutrilearn series. And I especially thank Dr. Gopika Sekhar Madam, who had wholeheartedly agreed to deliver the inaugural session in a rather short notice. It was a very rooted, basic, simple thing. I was busy writing notes, actually. I felt like I'm in a classroom. So it was a very practical session. And I think it was of immense help to all those who have attended the gathering. For the sake of formality, I also thank Dr. Geeta Madam, my guide and support, the President of Nutrition Chapter, for coordinating the program, for arranging the session. And last but not the least, I thank all the participants. We had around 100 participants at the beginning of the session, for those who have taken the time and attended the meeting in full. Thank you once. Thank you again, all.
Thank you all.
Gopika Madam, it was wonderful. Keep it up.
Thank you, sir.
We'll all attend again and again. This is wonderful. Thank you.
Sir, we'll be having every month session.
Thank you.
Definitely
will attend. Because
all the participants, kindly, if you have got any topics which you are interested, you can send us, and then we'll be able to find time for some of them.
Yeah.
Okay. Thank you all. And a safe journey, and for the great experience of Pedicon, Calcutta.
Yeah.
And best wishes to Elizabeth Madam for...
Thank you.
Best wishes to Madam.
Congratulations, Elizabeth Madam, for getting the result.
Thank you, Madam. Parvati Madam.
Well, Gopika, it was a wonderful talk. Well
Thank you,
covered.
madam.
Everything
Thank you.
well covered.
Thank you, Madam.
Thank you. Thank you.
Thank you, ma'am.
Thanks. So we'll leave the session.
We'll all leave. Okay, thank you.